questions might be based on approach as well. Next.
Yeah. For all the other AMLs, irrespective, you use chemotherapy. Yes, you can use hypomethylating agent like destabine also. But in a curative intent, chemotherapy remains the standard of care. Ultra-IT or not conventional chemotherapeutic drugs, they are mainly differentiating agents which we use in APML.
And now oral azacitidine is available with oral venetoclax. So that is also an approved therapy, which if we call it as oral both. So for that question, the straightforward answer was APML. Mitomycin C, 5FU as radiosensitizers. Straightforward answer is your carcinoma anal canal. So carcinoma anal canal can again be an adenocarcinoma. So see very clearly, only if it is a squamous cell carcinoma, then you are supposed to do chemoradiation alone with either capecitabine or 5FU along with your mitomycin C. The option of 5FU cisplatin with radiation is still a category 2B. So only this mitomycin with one of your 5FU or capecitabine is the category 1 recommendation for anal canal squamous cell carcinoma.
One quick questions to guys who probably would have qualified or anyone can answer. What color is mitomycin, the drug?
So these will be the basic questions asked to you in the interview. So how do you mix? How do you, what color it is? How do you manage extravasations?
It is mainly grayish blue or some even say purple, but grayish blue. That is the color basically. What are the other colored chemotherapy drugs that you know of?
Guys, you can actually start talking.
Red. Mitoxantrone, right? Doxo is red. Methotrexate yellow. Methotrexate yellow is a very important practical question because intrathecally the drug that you give ideally is yellow, that is methotrexate. Vincristine you can never give intrathecally because the patient is going to die immediately within 1 or 2 hours, right? So vincristine cannot be given intrathecal. Methotrexate can be given intrathecal. It can be given IV, it can be given intramuscular, it can be given even oral. Subcutaneous is not given. Whereas cytarabine is available as a subcutaneous form, it can give as intrathecal, intramuscular, IV also, but not oral form. So that is about the drugs and the colors. These are the basic concepts that you'll need to know.
So surgery and radiation, not a primary modality of treatment, then very clearly the primary CNS lymphoma. So primary CNS lymphoma has so many options now, but high-dose methotrexate based regimen is the basis of all your treatments. Consolidations, you have either radiation, you can even take up for temozolomide with radiation, whole body radiation, and so on. So for and also transplant. So transplant is one of the options of consolidation. Radiation is an option for consolidation, and also high dose cytarabine etoposide. So these many options are there for consolidation. But for the induction treatment, you basically use high dose methotrexate based regimen. So the question was back to the question. So probably they meant radiation as the primary modality of treatment. So so be very careful when you are attending to the questions. So if they had asked, see, this is from the information which you people have, they asked both surgery and radiation as a part of the treatment. Surgery is never a part of your PCNSL treatment. But when it comes to meningioma, again, radiation might not be a part of the treatment. So understand the question well before you answer. For here, the probable answer is your primary CNS lymphoma. So
why don't you see rituximab here? You see high-dose methotrexate as the treatment option. Why don't you see rituximab? We do use rituximab in all patients with primary CNS lymphoma. The reason was recently there was a trial, I think 2020. We probably is a major, but the regimen that you end up using is much more higher dose of methotrexate, which is slightly difficult. And but as a routine practice, we end up using rituximab, high-dose methotrexate, procarbazine, or temozolomide, vincristine. These are the drugs that are used. But still, the most important backbone is high-dose methotrexate.
So this was another, from what you have given, elderly male with pancytopenia and splenomegaly. So, sir, from your end. So,
yeah. So I don't know what exactly was the description and the history of the question was, because it could be hairy cell leukemia, it could be marginal zone lymphoma as well. So again, these patients tend to have involvement of the blood, splenomegaly in all cases, in splenic marginal zone lymphoma, where you can get villous lymphocytes. Even hairy cell leukemia presents as nearly same. So exactly what was the description? If somebody can tell, we can probably come back to that question later on. Okay. And hepatitis C is an important factor that you need to take whenever there is splenomegaly. Hepatitis C, and probably treatment for that is one of the most important aspect as well. Okay. So Vijay.
So this is another easy table for us to understand the differences between hairy cell leukemia and splenic marginal zone lymphoma. See, clinically, you are going to see a patient with large spleen, no lymph nodes, and a marrow which is showing some kind of lymphomatous involvement. But most of the times, you'll be very clearly seeing hairy cells in a hairy cell leukemia. But if they are not giving that and trying to derive answers from all your immunophenotyping, then this set of immunophenotyping, you will have to remember the very classical hairy cell leukemia immunophenotypings like CD25, 103, 11C, along with your basic markers like your CD20, CD22 as well. Whereas in the other end of the splenic marginal zone lymphoma, these might be absent. So this is one step to understand. Annexin A1 and TRAP are positive in your classic hairy cell, but negative in your splenic marginal zone. Also remember, there is another variant called hairy cell leukemia variant, wherein these two can be absent as well. Other than this, you cannot very clearly say whether it is a splenic marginal zone or a hairy cell, because both are one indolent diseases. For both, you treat only when there is a proper indication for treatment. Even if it is a hairy cell leukemia, this is another form of chronic lymphoproliferative disorder, CLPD, wherein there are particular indications for us to treat. So all your CLPD variants, hairy cell, splenic marginal zones, with if any peripheral spill, CLL, and so on, if all these come into a single group, you need some kind of symptomatic patients, either in the form of massive splenomegaly or cytopenias or infection, repeated infections, for us to start treatment for that particular variant. And splenic marginal zone, though being a low, indolent variety, you do only rituximab. You do not add a chemotherapy backbone to this treatment. And hairy cell leukemia, you do all your cladribine and other types of treatment. Next slide. FLT3 inhibitor, so very easy to remember is a FLT3 inhibitor. Classification is type 1 and type 2. You know, FLT3s are TKD and ITD mutations. So type 1 inhibit both, type 2 inhibits only one end. So you have the list of drugs here. Sunitinib is one of the FLT3 inhibitors, whereas imatinib is not a FLT3 inhibitor. That is the straightforward answer. Next slide.
We used to use sorafenib quite a lot when we did not have midostaurin. Post AML induction, in case somebody was FLT3 positive, we would be using sorafenib at that time as a maintenance. We don't do that now, though. Poor prognosis in AML is all except. So you have translocation 922, which is positive, is adverse. Translocation 69. CKIT, I'm not sure if CKIT was the option or ASXL, because I got from different sources. Favorable is inversion 16. So this is a different change that has happened from the past. So more importantly, what you need to know, the most important difference that has happened is previously FLT3 TKD was there. Now the TKD aspect is removed. FLT3 ITD, CKIT was the option. CKIT still becomes an adverse. Okay. So now the most important change that has happened here is with regard to FLT3. Previously, FLT3 positivity was considered as adverse. Now that FLT3 positivity has come to intermediate risk. So in case you got FLT3 negative and NPM1 positive, it is favorable. Any FLT3 positive is now intermediate. There's no adverse risk. That is the most important change that has happened, and multiple other newer mutations that have come into play. c-KIT actually, the more important is when it is associated with translocation 821. c-KIT is considered as the adverse factor for relapse in patient with translocation 821. As an independently, you don't see in this classification, but from what we know, c-KIT in the presence of translocation 821 portrays a poor prognosis.
And those in the red color in the adverse risk factors as mutated ASXL1, BCOR, EZH2. These are the set of mutations which are actually being studied in MDS, that is your dysplastic syndromes. And now that has also taken a place in your AML. Mainly when MDS is changing into AML or your MDS with EB1, EB2 and so on. Among that, you have to remember SF3B1 because that is a good gene in a MDS variety.
Right. SF3B1 is good in MDS. That is one of the things which has got good prognosis. But once there is AML, it comes as plausible because usually it is associated with other mutations as well. It doesn't come as an independent one.
So high dose busulfan, prophylactic antiepileptic. See, from whatever the literature is.
Akshay, you want to come in?
I think everyone can be made as panelists. That is what Dr. Who is there on the DocTutorial end?
Yeah, if others can be in from the DocTutorials team, if they can. Akshay, you raised your hand, or else at least probably you can write in the chat box in case you are not able to speak.
Let not the chat box be the only mode of communication. You can make all Akshay is raising hand. You can come in the I'll allow talking.
Okay, I'll just contact the team to make you make everyone this thing. Vijay, you can just continue with the.
So high dose busulfan is extremely epileptogenic, and previously phenytoin was the treatment, prophylactic treatment to prevent any seizure because of your high dose busulfan. But of late, we have seen that certain studies have shown phenytoin is not a good drug, and henceforth levetiracetam is trying to replace that. So well and good that they have given a single option as levetiracetam or phenytoin, so that you do not confuse with the other answers. So this is one such paper which says on the conclusion that phenytoin prophylaxis is obsolete as of now and possibly harmful. So all of you can actually talk. You can unmute yourself. If there is any problem, do post the technical issues in the group so that the technical team is able to sort out all those stuff. Right. So phenytoin or levetiracetam is the answer for your busulfan prophylaxis for anti-epileptic doses. Right. High dose methotrexate, which lymphoma. See, this is a little tricky. The straightforward answer is your primary CNS lymphoma. But do we use high dose methotrexate in DLBCL varieties as well, in certain varieties, as a confirmatory treatment, wherein you find some patients who can have a CNS relapse? There are certain things which will tell us that the patient might have a CNS relapse, or you can really calculate something called as CNS IPI, which will tell us a patient with DLBCL might have a high risk of a relapse in the CNS. Such patients, you have two options: either giving an intrathecal methotrexate or doing a high dose methotrexate at the end of your 6 cycles of RCHOP. So that is one other thought process, but the answer here is obviously primary CNS lymphoma. Capecitabine with a 5FU, very classic question. This has come up after so many exams. The next slide. So this is a slide which will explain you how different are the side effect profiling of your capsid. And when you practice, actually, you'll understand hand-foot syndrome is horrible when you are using apsidamine. And most of us have actually turned from K-POX to 5FU oxaliplatin, that is FOLFOX, just because you require a dose reductions because of this problem called as hand-foot syndrome. Rather, diarrhea is almost the same, 15%. So this is a small data which says that those are equal. But other things are actually handleable. Even you can admit for neutropenia, handle those. So it is actually clinician's preference, either they choose a FOLFOX or K-POX, because there is no difference between these two. The main differences are based on your side effect profiling. The answer here is a hand-foot syndrome, which is more common in your capsidamine as opposed to 5FU.
Yeah, as rightly told, Vijay, K-POX, we were using capecitabine. So the ideal dose of capecitabine is 1250 mg per meter square, which none of us have ever used. The recommended is at least 1000 mg per meter square, which is also difficult. 850 mg per meter square is what we end up using. Whereas 5FU, you are able to give much easier. And neutropenia, which is common, we can easily handle with growth factors, which are now available. Previously, that was the issue they had when they were using 5FU.
And capecitabine, 825 per square is usually a radiosensitizing dose. So dosing, remember these doses also, those very basic dose informations might be the questions in your interview as well. So cause of late hemorrhagic cystitis. See, there are various definitions, but straightforward, within a week, if there is any hemorrhagic cystitis, more so within 72 hours is called as early. And after that time period is called late hemorrhagic cystitis. Early is usually because of drugs. Late is usually because of virus. The next slide. So cyclophosphamide and methotrexate are out of the story. Among the viruses, BK virus and adenovirus are the common. There are reports that CMV is also one of the causes of your hemorrhagic cystitis. But for answering this question, BK virus would be the perfect answer. So delayed onset. See, this table or flowchart actually gives 2 weeks to 6 months. So the difference between early and late is very defined in multiple flowcharts. But just remember, early is usually because of drugs and late is usually because of viruses. So how does your BK virus spread? Is basically in your early years, in the patient's early ages, they would have got BK virus either through their respiratory tract, getting lodged in your kidneys, your mucosa of the bladder, which gets reactivated after your transplant. Next.
Okay, advantage of weekly paclitaxel cisplatin or weekly paclitaxel carboplatin over 3-weekly regimen. It is more toxic, means whatever, which was the right one, more toxic, inferior, same or better, preferred in young patients. Now, if the question was weekly paclicarbo and 3-weekly paclicarbo, I think this is what was more studied in carcinoma ovary. So there are multiple trials on how they probably decided that should we use it or not. Now, one of the most important trial was what is called Japanese Gynec-Oncology Group, JGOG 9. So which showed that weekly paclitaxel and carboplatin to be definitely much superior compared to 3-weekly paclicarbo, where the survival is going at around 100 months. So it was never imagined before that somebody could achieve such a very good results. So they felt that probably the study population was different. There is some pharmacogenomic difference on giving weekly paclitaxel and carboplatin. And in that, specifically, carboplatin was given once in 3 weeks, and only paclitaxel was given as dosed and given every weekly. Now, the American group and the European group tried to replicate this with multiple other trials, which is called MITO7, ICON, and GOG other trials, where they failed to show that weekly paclicarbo was superior or probably better compared to 3-weekly paclicarbo. So the option of it being same or better is again wrong. Inferior is wrong because there is one trial to say that. Now, all trials consistently have shown that the toxicity, especially in neuropathy, is much higher in weekly paclitaxel versus 3-weekly paclitaxel. The myalgia related to paclitaxel is more common with 3-weekly paclitaxel versus weekly paclitaxel. However, in an overall sense, it is definitely more toxic. Saying that, the advantage of weekly paclitaxel is in elderly or frail people, you can use it easily because you can always either delay or dose reduce whenever feasible. So you end up using a slightly lower dose to treat, but you can always titrate because these patients are coming weekly. Once you give 3 weekly and they end up in toxicity, it's always more difficult. So it is preferred in older patients, even though sensibly it is more toxic, but you can titrate it to your needs. It is not exactly inferior, it is not exactly same or better. So the answer would be here that weekly paclitaxel would be more toxic. Laryngeal papilloma associated with which HPV variant? You've got papillomatosis. In case that was the question, the answer is HPV 6 and 11. In case it was malignancy per se, it again becomes 16. Okay.
So drugs not used in the prevention of GVHD in bone marrow transplant. See, there are next slide. Next slide. So this actually gives you an overview of how GVHD happens. What are your targets? So there are various targets now. The recently approved one is your abatacept, the CTLA4 inhibitor. So you have various drugs, but by practice, what we are using is usually a calcineurin inhibitor, like your cyclosporin or cyclosporin A or tacrolimus. You have mTOR inhibitors as well, and very commonly used your steroids. This PTCY, that is your post-transplant cyclophosphamide, has become one of the very commonly used ones, more so in your haploidentical transplants for prevention of GVHD. So cyclophosphamide is also another drug, though being a chemotherapeutic agent. The effect of it on stem cells is going to be nil. Henceforth, it usually prevents the effector T cells rather than actually targeting the stem cells. So after transplant, on day 4 and day 5, sorry, day 3 and day 4, cyclophosphamide doses are given, which is called as PTCY or post-transplant cyclophosphamide. Along with this, there are a group of these drugs are also utilized in the treatment of your GVHD. Prophylactic agents are actually different from your treatment agents. So that difference is not very clear from this picture. So your methotrexate is also a prophylactic agent for your GVHD, but not your high dose methotrexate. So that will be the answer here.
Yeah. Methotrexate at lower doses, everolimus, we would be using it in a much earlier days. Now you have sirolimus, but more so we would be using tacrolimus and cyclosporin. Okay, so high dose methotrexate is not an option here. Now gemcitabine is used in which head and neck cancer? Now for nasopharyngeal carcinoma, gemcitabine is now category 1 recommendation for EBV associated disease. Most of these are considered as an EBV associated disease. So GemCis, either neoadjuvant or adjuvant treatment, has come as a preferred regimen. Now GemCis can be used in second or third line in other head and neck malignancy as such, but preferred first line treatment is in nasopharyngeal carcinoma. Peripheral neuropathy is a feature of which lymphoma? It is lymphoplasmacytic lymphoma. Usually they end up presenting as peripheral neuropathy with the present distal chronic symmetrical sensory polyneuropathy that is known, and they do end up recovering to a certain extent, not complete extent with treatment, but they do have a improvement post treatment. Ethate with germ cell tumor drug not to be used. Bleomycin, etoposide, paclitaxel, vincristine. This is straightforward. Bleomycin, because you know that they can have very high risk of bleomycin-induced pulmonary toxicity, and these patients, say if he's an athlete, he needs good lung function post this post treatment. So bleomycin is something that probably you try to avoid and use a combination of chemotherapy like VIP, right? In what other patients bleomycin can cause increased risk of pulmonary toxicity?
This will be a very commonly asked question when you are attending interviews. Germ cell tumors are extremely repeated questions, so be very thorough in all these basic stuff.
Okay, anyone? Bleomycin toxicity. What are all the risk factors for somebody to develop bleomycin lung toxicity? GCSF. GCSF has now become controversial. Previously, yes, it was considered that regular use of GCSF can increase. We still we do not use GCSF, but there are now studies to tell probably that it's not. Yes, bleomycin reach that level of bleomycin. Okay, high FiO2 is right. Oxygen. So post-treatment, in case somebody who's got a mediastinal mass and you are contemplating that this patient is probably going to go have a surgery later on, and probably he's going to receive general anesthesia. In these patients, you probably use VIP chemotherapy. Somebody who's elderly, past smoker, already compromised lung function, somebody who's got renal failure. In Hodgkin lymphoma, specifically, you are not going to use bleomycin with another drug. So these drugs are contraindicated to be used together. Which one? Fantastic. Brentuximab. Okay. So if you see, the approval of brentuximab is by replacing bleomycin. Okay. What is the toxicity of dose-limiting toxicity of brentuximab? Neuropathy. Fine. Yes. Okay. We already discussed this. Gemcitabine can be used in which head and neck cancer? That is, gem cells become the first line indication. For other head and neck, you end up using gem later on, but usually it is first line. Now, 52-year-old male has been operated for carcinoma of pancreas. Which of the following has shown survival benefit? Observation, RT, CTRT, gemcitabine. I want you to answer this and probably tell me why and what. This is a little tricky question.
So from the question,
Right.
actually, you have understood it is not borderline, it is not locally advanced. Clearly, it is an operated case.
Operated case and adjuvant treatment. Which one has shown a survival benefit? Anyone?
So when you read NCCN guidelines, you have to actually read the subtitles as well when you even get into the institute. So purely just seeing the NCCN guideline flowcharts alone will not fetch you the answer, because there will be smaller descriptions which will actually add up onto the main answer. So by the trials, gemcitabine is something that you can use as a single agent, and it has shown a survival benefit compared to observation. Gemcitabine versus 5FU based treatment, no difference in survival. That was the SPAC3, but lesser toxicity. Gemcape versus Gemcape was a better one. Folfirinox, modified folfirinox versus Gemcape, modified folfirinox is better. So that is how all the regimens have done. So your recommended regimens include modified folfirinox, gemcitabine, capecitabine, gemcitabine as well. So that is even a category 1 recommendation that it has shown survival compared to only observation. Now, only radiation has not shown benefit. Only CTRT is not used. Now, the role of radiation basically comes because all your, so if you have a general idea of who predominates the
medical word in radiation oncology. It is United States. So anywhere your chemoradiation comes, chemoradiation in solid malignancies, even in resected. So previously, even in stomach, chemoradiation was a standard treatment protocol. They still use what is called McDonald's regimen. For pancreas also CTRT is used, but there is a fine line. So addition of chemoradiation to chemotherapy is suggested, can be used, okay, but not chemoradiation alone. And for FOLFIRINOX, there is no role for adjuvant chemoradiation. So in case you have to carefully choose one, in case there was an option chemotherapy and chemoradiation, yes, probably it has shown survival benefit. Gemcitabine alone, yes. CTRT alone is not used. So the answer here would be gemcitabine. Okay. So this is chart from up to date. So for anyone more than T1N0, so this is one of those malignancies that anything equal or more than T1N0, you probably consider giving adjuvant treatment, and adjuvant chemotherapy with or without chemoradiation. It is not only chemoradiation. Okay, this would be the treatment aspect here. Okay. Now we discuss this weekly paclitaxel carbo versus 3 weekly paclitaxel carbo. It is not toxic. I can't hear anyone.
Point to add on to the pancreas story. You know that you have 3 classifications: operable, borderline, and locally advanced. So far, for borderline, we were using neoadjuvant chemotherapy followed by operability and then do surgery. Now the recent updates are trying to bring in neoadjuvant chemotherapy for an operable pancreatic cancer as well. So now the NCCN is gradually changing, trying to put that also as an option. Probably that might become the only standard of care as well. So neoadjuvant chemotherapy in pancreas used for operable cancers also.
Yeah, previously we used to discuss what option of chemotherapy is not approved as adjuvant treatment. So if you see what is approved in metastatic but not in adjuvant treatment, so you got modified FOLFIRINOX, which is both in metastatic and adjuvant. It is a standard of care. Even in neoadjuvant you can use. GEM-CAPE is again approved in both. GEM is approved in both. Now GEM and nab-paclitaxel was always in metastatic. Recently, there has been a study which looked at perioperative using 2 cycles of gem-nab-paclitaxel and then proceeding in surgery versus doing it as an adjuvant, and there is a gradual benefit towards neoadjuvant therapy, and probably it is going to come next. Okay, 35-year-old stage 1 seminoma treatment of choice, surveillance, 2 cycles of BEP, 3 cycles BEP, radiation to pelvic lymph nodes. What is the answer here? What's the answer here? Okay, the answer here would be surveillance. In case the option was surveillance, single agent carboplatin, radiation to para-aortic nodes, all 3 options are right. Still, you would probably prefer surveillance. But in seminoma, active surveillance or adjuvant carboplatin, you are not using BEP. Remember, you don't use BEP for stage 1 seminoma. And the radiation is para-aortic radiation. It is not pelvic lymph node radiation. So the answer would be surveillance here. So germ cell tumor are something that everyone is fond of. Harrison has got these nice tables, and even our QRP sessions, we have discussed this in detail. Please go through it again. And K5FU we will discuss. Yes, Vijay.
For seminoma, so you will have to remember the high risk features in a stage 1 as well, wherein rather than surveillance, chemotherapy is still an option, like your tumor size of more than 4 centimeter and a retitestis involvement. So these 2 are high risk features of a seminoma. And when it comes to non-seminomatous germ cell tumor, embryonal component of more than 50%, and the other ones are
LVI.
Lymphovascularization. So these 2 are the high risk features in a stage 1 NSGCT to make sure that you give chemotherapy rather than opt for surveillance.
Surveillance. Okay. So otherwise, usually the surveillance would be the standard. But in case somebody who's got retitestis involvement and size more than 4 centimeters, these are probably the higher risk factors where you would choose chemotherapy over surveillance. NSGCT, it becomes embryonal carcinoma of more than 50%. And in presence of LVI, you'd probably choose chemotherapy over surveillance. Now, 5FP toxicity, yes. Young male mediastinal mass MIC2 plus positive. Next test, what is this? This is a tricky question. Okay. And this is probably because AIMS, I was discussing with a colleague of our student only who's now in AIMS now, why probably they end up asking these questions. Now, they have this common discussion of MIC2 plus being CD99. We never report any reports as MIC2 plus positive. We usually report it as CD99. To make the question slightly complicated, they have reported as MIC2 plus. Now, whenever CD99, you have a small round cell tumor, you need to rule out Ewing sarcoma, PNAT. Now, these always show very strong membrane CD99 positivity compared to other malignancies. If CD99 is negative, Ewing sarcoma or PNAT is unlikely. However, if CD99 is positive, it needs to be confirmed with additional molecular testing to look for translocation 1122 as many other neoplasms, including lymphoblastic leukemias, lymphomas are usually CD99 positive. So, young male presenting with mediastinal mass, it is a very unusual small round cell also was mentioned in the question. Good. So, mediastinal mass as a presentation for Ewing sarcomas, extremely unlikely. Okay. So, somebody presenting with a chest wall mass, I can understand that probably you're thinking of Askins tumor, Ewing sarcoma, yes. But per se, mediastinal mass presenting as a presentation of Ewing sarcoma is very unusual and unlikely.
So, whether number CD99 is equal to MIC2 plus or not, that's what.
Yeah. Okay. So CD99 positive in this patient, probably the option would be TDT. Now, why was this question so favorite for AIMS? I got this paper from one of our students only. Alan Shaji sent me this paper. So this is a paper that is published by AIMS where they've used MIC2 as a marker, and they found that somebody with an aggressive lymphoma had MIC2 positivity. So just to tell that there has been some discussion going on for last few years of MIC2 or CD99 names, and that is why this is a favorite question for them probably. This has been asked once before, I think 1.5 years back. But otherwise, you usually kind of do not discuss CD99 as a primary modality to diagnose a mediastinal mass. There are other ways to diagnose mediastinal mass. But in case CD99 positive in anterior mediastinal mass in a young patient, I would still think of lymphoblastic lymphoma as a diagnosis and do TDT next. Least hematogenic drug, I am not sure if the first option was imipenem or ifosfamide. Cisplatin, vincristine, dacarbazine. Even if it's imipenem, the answer would be vincristine here. So you have the Hesketh scale, that is the scale that is used for hematogenicity. The option was imipenem. Yeah. Okay. So it still becomes vincristine. Vincristine is minimal risk. We don't give any antiemetic before administering vincristine. So Hesketh scale, there is a bigger table in probably LCCN that you need to go through or our classes as well. Know this of which are the drugs which are associated with high level of high risk hematogenicity. Cisplatin, any dose, cyclophosphamide more than 1.5 gram. Newer addition is carboplatin of AUC 4 or more is now high risk toxicity. Adriamycin of more than 60 mg per meter square. Adriamycin cyclophosphamide combination. Now all this becomes again high risk. Vincristine is classically a very minimal risk. Even bleomycin is other very minimal risk. So you don't administer any antiemetic before this. So say day 15 germ cell tumor occurrence, we don't give any antiemetic before giving bleomycin. And for vincristine as well, we don't give any antiemetic. In case you are using an antiemetic when you're giving vincristine, what would you avoid? in case patient had come with vomiting and you're planning to give NK1,
What is the most
okay.
common side effect of
What is the most common side effect of incretin? Most
right?
common or most worrying side effect? Yeah, emised you would avoid. Okay, you would avoid emised or
But SADH is not the common side effect.
SID is not. Constipation is extremely common. Going to ileus is pretty common. SIDH is known with incretin, but it's not the most common side effect. So constipation, and you don't want these patients to go to ileus. Emised, palnosatron, granisetron, all are known to be causing constipation more than this thing. I would probably prefer to use a prokinetic like Perinom in these patients in case these patients had vomiting due to any other reason as well. Okay. Not an indication for breast MRI. A slightly tricky question. Evaluation of breast implant, definitely you would prefer MRI. Screening in high risk population, like say somebody who's got BRCA mutation, definitely yes. Axillary node positive breast UHG and mammo negative. Somebody, this is basically a carcinoma unknown primary status. Again, you would prefer MRI. Post NSCT, it's not an absolute contraindication, means you don't do MRI as such. There are now studies to see MRI based pathological complete response and trying to avoid surgery. So in that case, probably you'll use MRI, but of the options, post NSCT, routinely we don't use MRI.
And post NICT, if you are trying to do a breast conservation surgery, again, MRI has a part in that. But in that question, possibly the answer is NICT.
Yeah, which of the following is common feature in patient with multiple myeloma? I'm not sure of the options, but the answer was probably osteolytic bone lesions. That is pretty straightforward. Who first established medical oncology in AIIMS Delhi? I don't know why they've asked. They do end up asking such questions once in a while. It is Dr. Vinod Kochupillai. Madam was instrumental in starting the department of medical oncology. Which was I remember had been asked was when was AIIMS established? That is year is 1956 and Department of Medical Oncology in 1984. Weird facts, not of any use, but probably use when they ask in your viva. Okay, we pick the right tumor at drug combination: PTCL, rituximab, follicular lymphoma, lenalidomide, CA breast, daratumumab, high-grade DLB cell, bendamustine. I'm not sure of all the options. But the option here would be follicular lymphoma, lenalidomide, because this R-square regimen in relapsed follicular lymphoma you do use. Rituximab in PTCL, no, because it's a T-cell lymphoma. Daratumumab in patients with myeloma. Bendamustine not in high-grade DLB cell. Any low-grade lymphomas you use bendamustine rituximab as a combination. Pick out the wrong combination. This was, I think, pretty straightforward. Translocation 1121 was the option, I think, there. So isochrome 12P tells that it is a germ cell tumor. One of the ways where they can frame a question like carcinoma unknown primary, say somebody has come with mediastinal mass, you do investigations, you're not sure what it is overlapping, it comes as small blue round cell tumor. Still, are there any way to find out that if this is a germ cell tumor? Trying to identify if there is an isochrome 12P there, that would tell you that this is a germ cell tumor. Okay. Now, these translocations are important. We are, again, I think we are discussed in our QRP sessions as well. There are other translocations also, but most common ones are these. Okay. Most common symptoms in a patient with ovarian cancer. Can anyone tell what exactly was the question? Now, in case you ask what are the most common symptoms, abdominal distension and bloating is the most common symptom. Constipation is less often seen. The bowel disturbances are less often. DVT is also pretty common in patients with ovarian cancer as probably a presenting symptom. Probably around 3 to 5% of the patients can present as DVT. Constipation is less often seen. Bloating and abdominal distension are the most common symptoms.
They had given it as a symptom complex, and then they had asked like A plus B, A plus B plus C.
Okay, fine. They did not tell that which is more common than, like, not in the preferential order as such, right? No. Okay, fine. Thank you. High-dose methotrexate used in therapy of, again, straightforward, which solid malignancy? Osteosarcoma is one solid malignancy where high-dose methotrexate has definitely shown benefit. The doses are much higher 8 to 12 gram per meter square. Now, when you go, methotrexate is one of the most common drugs that is discussed. So I'll have a quick rapid fire here. Okay, I prefer if anyone can answer on the mic as such. Now, who discovered methotrexate?
You can type as well.
Yellaprada Subbarao.
Yellaprada Subbarao. What was the first drug used in acute lymphoblastic leukemia? Was it methotrexate?
What is methotrexate? Otherwise called aminopterin.
Aminopterin. Okay, aminopterin. Amethopterin is methotrexate. Aminopterin was the first drug that was used. Now, you have told that the color is yellow color. Now, I need to reconfirm what exactly is high dose methotrexate. I think anything more than 500 mg per meter square is high dose, but we will check again and get back. There is some difference. Please find out by yourself also what is low dose versus high dose methotrexate. Now,
references
up
it is
to date gives us 500. Yeah. Okay. So, what are the routes of administration? I have told all except subcutaneous, it can be used. Now, color I have told. Now, so in case you are planning to give somebody high dose methotrexate, how will you give it? What are the basic principles that you need to use when you give high dose methotrexate? Urine alkalization is the most important one. So how do you achieve it? You give usually sodium bicarbonate along with half saline or dextrose or even saline as infusion at rate of around 3 liters per meter square is what you're supposed to use. Try to maintain urine pH more than 7.5 you give. In case pH is coming less, you again give additional boluses of soda bicarb. So once urine pH is more than 7, then you give methotrexate as an infusion. In acute leukemia, you give a 24-hour infusion. In osteosarcoma and primary CNS lymphoma, it is usually a very short infusion of 2 hours. The longer the infusion, more is the toxicity. The leucovorin nomogram, okay, that probably I will share one of the images in the group. Okay, now basic principle is once you are given methotrexate, you start checking the methotrexate level after a certain time. So usually there is some protocols use 24 hours after methotrexate, 36 or 42 hours. We used to have a protocol of using more than at 42 hours, do the first level of methotrexate. Correct, Vijay?
Yeah.
Yeah. Okay. At 42 hours, when you do methotrexate, it should be less than 1. Okay. At 48 hours, less than 0.4, and ideally clear by 72 hours.
I'll share the details.
Yeah, we'll share the details of it. So, but basically, you start leucovorin at least 24 to 36 hours after kind of initiating. Usually, 36 hours is what you use. Different protocols have different nomograms, so they might not. But it is the principle that you check methotrexate level and give leucovorin. In case say methotrexate levels are higher, you are supposed to escalate leucovorin. You continue the hydration, check the urine pH, check creatinine. Creatinine is not a good value because one, it takes longer time once kidneys are affected, and say there is a 25% jump of creatinine even before your MTX level comes. Be careful, these patients are going to have a toxicity. Fine. So in elderly patients having already pre-existing renal issues, be careful. Be careful in using drugs like penicillin or penicillin group drugs because this prevent methotrexate. So be careful in using such drugs. So most importantly, in case the patient does have a toxicity, you are in soup. Why? Methotrexate cannot be dialyzed. Okay. Leucovorin will help protecting normal cells, but yeah, which is the antidote as such? Glucarpidase. And trust me, that's an orphan drug. I will someday tell you my story of high-dose methotrexate toxicity when I have time. It is bloody expensive and you can't get it. So pray that your patient never has methotrexate toxicity. So you have to continue hydration and leucovorin until the methotrexate, serum methotrexate clears less than 0.03 or 0.02. Again, varies on the protocol. Okay, fine. And say patient has methotrexate toxicity, you can imagine every other organ the patient can develop toxicity, starting with kidneys, acute renal failure, LFT derangement, CNS toxicity, lung toxicity, cytopenias, which last for weeks together, skin toxicity, skin becomes dark and just peels off just once you apply pressure. So every other toxicity you can imagine, and it's pretty bad. So always pray that you don't have methotrexate toxicity. Okay, leucovorin rescue is again used in high dose methotrexate. Why did you use leucovorin with fluorouracil?
Is it for a
Primary lymphoma, different protocol is there. So RMPV is a protocol that we commonly use, where we use 3.5 gram per meter square. You have MTR regimen where you use 8 gram per meter square. So you end up using a higher dose in primary CNS lymphoma, but shorter duration, only 2 hours or so. Okay. Somebody raised their hand.
You can talk.
Yeah.
It improves
Leucovorin- Qutub Minar, nice name. Why do you use leucovorin in fluorouracil along with fluorouracil?
Is it for
Reducing toxicity?
for improved efficacy.
Basically, it makes sure that the 5FU destruction is being limited and directs more of your 5FU into the activity pathway.
Not exactly to increase the delivery of the drug, but what it does is leucovorin complex with 5FU forms a tertiary complex which is much more stable in inhibiting DPD and thus improving the efficacy of fluorouracil. PMA post-transplant. Okay, so this is cyclosporin or tacrolimus. You have multiple other drugs which can cause this. So 2 other important drugs that are associated with HUS, TTP, TMA, any of these names you can use is mitomycin C, gemcitabine, and even bleomycin, cisplatin. Mitomycin C is idiosyncratic. You never know in case these patients can land up in HUS. Gemcitabine can be idiosyncratic or dose related, but mitomycin C is notorious to cause HUS. Okay. Most common cancer in pregnancy, this is breast. There is higher risk of malignancy during pregnancy, but pregnancy per se is more protective. Partum, more the pregnancy is more protective towards development of breast malignancy, and breast malignancy during pregnancy is associated with poor outcome. They are very aggressive. Say patient has been diagnosed as CA breast in 2nd trimester, what will you do? What drugs you can give, what drugs you cannot give. Doxorubicin you can give, cyclophosphamide you can give, you can't give taxanes, you can't give trastuzumab. Okay, so taxanes you avoid, at least till 3rd you can push and sometimes give. It causes mainly oligohydramnios. So otherwise, no. Which are the drugs which you can definitely not use in patients with pregnancy, especially 1st trimester? You can't hear, somebody is trying to talk, I think, but fine.
Also,
Antimetabolites, especially methotrexate, you cannot use. Alkali-acidic agents, no definite evidence to avoid as such. Adriamycin, cyclophosphamide, which is something that we use. Methotrexate is something definitely not to be used. Even other antimetabolites you would not use. Multiple myeloma stage 2 according to ISS, straightforward, nothing major, only options I've tricked. I don't know what exactly was the question, but this is ISS. We've got what is called revised ISS now. So where you have albumin, microglobulin, high-risk cytogenetic features. In this, the high-risk cytogenetic features include 414, 1416, and 17P. 1420, which is also considered as a high risk, is not there. In case somebody has got 1114, okay, translocation 1114, I think I am right. Which newer drug can you use?
for that variety alone.
If somebody has got translocation 11, 14, which newer drug can you use? Venetoclax, fantastic. Okay, so venetoclax is used in only this one subtype. Somebody has got translocation 11, 14, you can use venetoclax. Okay, orally available platinum compound. This is basically not available. This was something that was Deepak, come in. Deepak, you have a question or anything to tell? Okay, orally available platinum compound. This is Satraplatin. Most common HPV causing head and neck cancer is HPV 16. Streptococcus pyogenes and Serratia marcinans combination previously used for treatment of which cancer? This, I think, in our classes we end up discussing some of the histories. So this is sarcoma, or what is called the Goldstock. So he ended up using in patient with sarcoma and showed a response. The first probable evidence of immunotherapy, which is the other similar principle that has been used for a long time, and we still use it. BCG, fantastic. BCG in bladder. Okay. Full name of CAR-T, I think, was this a question? I'm not sure. I've just framed the options. It's chimeric antigen receptor T cell. Barrett's esophagus predisposes to which type of carcinoma? It is adenocarcinoma. This is your table from squamous cell. Squamous cell is mainly irritation due to multiple more corrosive substances can cause, whereas Barrett's and obesity GERD is for adenocarcinoma esophagus. Okay, this way we can discuss that which can avoid surgery or radiation. AIM without conventional chemotherapy is M3. Melphalan as a condition regimen is myeloma. As a single agent is myeloma. You do use melphalan in others like busulfan and melphalan. Bumel conditioning also you use, but as a single agent condition regimen is myeloma. Now, what is the dose limiting toxicity of melphalan when you use for myeloma? Means whatever transplant?
Don't tell myelosuppression. That is what is aimed at.
Mucositis, right? How do you reduce mucositis?
Oral cryo.
Yes, oral cryo, or in the past, or we still use it, ice candy sucking. Okay, we used to the previous night we had to get those ice candy containers and keep ice candy sticks. That was also a resident's job. So ice or photodynamic or more so cryotherapy is now kind of more preferred protocol that you use. Palifermin is mentioned but never used. It is never used as such. Now, remember, whenever somebody asks what is the dose limiting toxicity of a certain drug for transplant, it is never myelosuppression, because you want myelosuppression. That is your aim. So you end up using drugs where the dose limiting toxicity is okay when you attain a certain level of myelosuppression. So melphalan you can use at that dose because you have myelosuppression, but you can rescue with stem cell. But dose limiting toxicity is myositis. You don't use doxorubicin because for the dose that you have to achieve a really good myelosuppression, you will end up 200 mg per meter square is the dose. Yes. So for the doxorubicin, if you're using for transplant,
140 mg per meter square. So
140, 160 mg per meter square also you can use. You don't have something called a myelosuppression dose. You have what is called a transplant dose. Now, or whatever conditioning regimen dose. Doxorubicin you don't use because your cardiotoxicity is much higher compared to the myelosuppression that you can get. Okay. Okay. PS ECOG performance status. We have kept on discussing this. You have got PS2 is somebody who's ambulatory, capable of self activities, and is up and about more than 50% of this thing. Now, what is the performance index that is used in pediatrics?
Scale used there.
You ski.
not the Zobran.
Lansky. Okay, Lansky is pediatrics, which is same as Karnofsky, only the way US is different. It is 0 to 100. What is Zubrod score? Deepak mentioned as Zubrod.
And to add on, remember 0 of Karnofsky is dead. 0 of ECOG is totally different. It is pre-disease performance.
Okay, Zubrod is same as the ECOG PS. Okay, Zubrod score is same as the ECOG PS. Mitomycin 5-FU, anal canal, FLT3, sunitinib, anti-epileptic, somebody with severe economic constraint with CML, TKA of choice, straight for imatinib. Dasatinib option I have not given because even now dasatinib has come down cost-wise.
Dasatinib was one of the options. Bosutinib was not there.
Dasatinib was one of the options. Okay, even if dasatinib is one of the options, imatinib is still the answer. Okay, so now the toxicities of these, I think all of us know what toxicity, which is the newer TKA, the latest TKA that is approved in patients with CML.
One of the newer CML drugs.
Olivara. No, I don't know if that's the brand name. Asciminib. Asciminib is the drug.
Not asimbatinib.
Asciminib.
Asciminib. That is one other drug which is used in your T315I mutation. Also in other mutations, apart from ponatinib, so asciminib, ponatinib, and transplant. These three are the options for T315I mutation.
Okay. With this, we have discussed late hemorrhagic cystitis, editing with olevratinib. Okay, I don't know if that is something that is new. We'll have to check. Peripheral neuropathy, lymphoplasma, laryngeal papillomatosis. I think we are done. So, so you know that this time it was more so straightforward. I think your Viva as usual is going to be same. On the clinical side, they are going to stick to the basics of the drugs or approach to a particular malignancy. So think of 1 or 2 malignancies, be very thorough with it, right? And please read your thesis because stats is something they end up asking based on your thesis. Might not have any major relation, but still they end up asking what research you have done and try to see from there where to go. If you've had oncology experience, it's well and good. Good news for you is there are, I don't think there is one or no non-acad SRs. Previously for there used to be non-acad SRs, so now you don't have. So things are open. All of you still have a chance to kind of cracking the exam. So all the best, and let's see. We'll have the interview session this week. Okay. So we'll close the session in case anyone else has any questions to discuss or anything. Okay. You can probably even get back to us. Thank you. Thank you for being there. Okay. Please feel free to discuss whatever you have with us directly. It might take some time for us to respond because our clinic work is also quite hectic. But at least by the end of the day, we'll try and get back. Okay. Thank you.